Okay, so this is the Zoom recording for week 9. This is on mental illness. Going to focus on schizophrenia and ADHD a little bit and apps for that and kind of lead into the stories that you read about the institution in New York there. Okay, so just kind of FYI, the second part of your capstone is due 4/29. It's assigned through this class. You have to post it through this class. Don't get too concerned about this. It's not that big a deal. It's just kind of adding to what you already did. Your first capstone, I'm not sure whether it's with Katie or Emily, on your level 1 experience. What you're basically adding is the intervention plan. So if you look at the rubric, this is part of the rubric. It's posted on Canvas. You're talking about their goals, long and short-term goals, what they did, the therapist did for the interventions, any unmet needs you thought that they weren't meeting that could be addressed, and some reflection. What went well, what you think of it, what you thought of it, that sort of thing. Couple, 2 or 3 pages are just kind of adding on to what you've already done, and then pass that in. Ask me if you have questions. I think it's pretty straightforward. Again, the focus of it, you're adding the treatment plan that was done. You say, well, I can't remember the goals. I'm not sure what they did. Kind of think back to what the client was like, whatever. You can make up goals, make up intervention plans that are appropriate. Doesn't exactly have to be what they did. It's kind of your idea. It's the best. Most students just use what the therapist did, but if you can't remember all the details, whatever, you can make it up as long as it's logical and appropriate to what is going on with the client. So ask me if you have questions on that. It's not due till the end of the semester, but it's a good thing to kind of get going on that. These are the exam questions, potential exam questions from this week's lecture. Let's look at mental illness. We're going to shift our focus on mental illness. You've had a lot of it from a kind of a medical viewpoint that you've had with Kim's classes. This is more from the client's point of view, more of a contextual point of view. And you'll see pretty quickly how that is different. We're looking at the idea of juncture with mental health clients versus just reducing their symptoms through medications. Again, this is going to make different from what you've already got a little bit. A lot of stigma, as you know, around mental illness. It's very much so an exploding population, kind of a non-visible disability. Mental illness is kind of stigmatized and devalued in the United States, but it's very, very common. It affects 1 in 4 people. These are some movie stars that have mental health issues. A lot of links with mental illness and poverty. Home health saw a lot of that. There was links with severe mental illness and severe poverty. Limited access to services for mental health, limited insurance coverage for mental health. Again, it is not considered, I think it's part of the stigma in our culture on mental health. A lot of links between mental health and other health issues. You know about the ACE study showing how the childhood trauma leads to this lifelong pattern of health issues. And you'll see pretty quickly, even if you don't want anything to do with mental health, that you can't really get away from it. It is very much married with physical issues as well. They seem to really go together. You'll see clients and they have mental health issues and physical issues. And it makes sense. The physical issues can lead to mental health issues and kind of vice versa. They're very much intertwined. The elderly, I saw a lot of mental health issues with the elderly around depression, isolation, anxiety, lost loved ones, lost work, what's meaningful to them. We'll talk more about this in later weeks, but there's a big connection between mental health issues and older folks. Okay, so now we're looking at mental health from more of this contextual perspective. And really more than any other diagnosis, mental illness does not happen in isolation. Excuse me for that, sneeze. Mental health does not happen in isolation. It's very much a combined kind of thing with the culture. Has a lot of impact on mental health diagnoses and how it's treated, we'll see pretty quickly. Family dynamics, trauma history, social expectations, cultural beliefs, and prevailing medical knowledge. To be honest, around mental health is quite limited. We don't really have a lot of stuff to offer people with mental health. We don't really have a cure. Take this pill and it will get rid of your bipolar disease. We'll get rid of your depression. It's a lifelong management kind of thing. And the medication, as you know, is very tricky. It's up and down, constant management of the symptoms in the medication. But it has this contextual level to it that we'll see. It seems to make it worse depending on where you live and that sort of thing. And the three we're going to use as examples to see that cultural contextual influence on mental health. It isn't just a brain organic or neurochemistry thing. Definitely that's part of it, what's going on in the brain, what's going on neurologically, but it's only one part of mental illness. What we're going to look at is the schizophrenia, especially a little bit ADHD, and then the stories that we're doing around institutionalization of mental health. Schizophrenia. They're not really sure what causes schizophrenia. Definitely seems to be some kind of organic brain component to it with some schizophrenics. I mean, you look at this MRI and you can kind of see that. Not so much others. And some of this stuff that goes on with the brain is schizophrenia for sure, but some of it they're learning now is a result of the medications. The medications due to the brain over the long term is not a pretty picture in terms of a chronic schizophrenic. So what causes it? Definitely a genetic link. They're not sure exactly how. There's also this cultural environmental mix that seems to influence schizophrenia. And it's kind of hard to wrap your brain around. How can culture influence schizophrenia? How can the environment influence schizophrenia? And we'll kind of talk about that. There's definitely no clear cure for schizophrenia. It's a management kind of deal. Some folks, especially in different approaches, as we'll see beyond medications, are able to function quite highly at a high level in terms of community and work and that sort of thing. Others, not so much. So we're looking at the social contextual forces behind schizophrenia. And this is kind of flipping things a little bit. It's kind of tricky, different from what you've kind of been taught a little bit. It kind of broadens the perspective of kind of what's going on with schizophrenia. Schizophrenics in the Western cultures, especially this country, United States, fare worse than schizophrenics in the third world. So kind of wrap your head around that a little bit. Schizophrenics in India, Africa, South America, where there's little to no mental health services, little to no medications, they appear to do better than schizophrenics in our country. What I mean by they appear to do better, they're more integrated in the community. They're working at jobs, they're involved with their families, they're not institutionalized, they're not chronically in and out of hospital with psychotic episodes, living in assisted living facilities. They're more independent, they're more into the community. Why that is, I'm not really sure, but it kind of begs the question, is our approach really the best approach? When I say our United States approach. The number of individuals with schizophrenia on disability, these are schizophrenics that are unable to work, so they're getting Social Security benefits, has continued to rise in the United States since the continued advent of newer and better medications. So these medications, in theory, are getting better and better at stopping the voices and making schizophrenics better able to manage their symptoms. But it seems like with these new meds, there's more people that are isolated, not working, not part of the community, not part of society, more than ever. So again, it's a contradiction. Why are the medications making people more disabled? The number of relapses of schizophrenia has increased dramatically since the introductions of modern psychiatric medications. Not saying that the medications are crucial, don't play a huge role, but oddly, schizophrenics are relapsing more and more and more on these medications. So what is it about the medications that's causing the relapse? Is it non-compliance? Or is it compliance? It's the medications themselves. These are questions we haven't really fully answered yet, as is the case with the brain and mental health. A lot of kind of conundrums around the brain and cultural and society things that seem to be driving the incidence of schizophrenia, especially in this country. They've done some limited long-term studies, and it's very limited in part because every schizophrenic now in this country is on a medication. But prior to the 50s and 60s, there were schizophrenics that were not on medications, and they kind of went back and compared the ones that didn't use meds versus those that did use meds. Again, it's limited, but it seems to make a connection between the more the patients use medications, the more they relapse. They have psychotic episodes, they're in and out of the hospital, that sort of thing. Again, that's flipping around, and you're going to get questions on this, so it's counterintuitive to a lot of what you've already kind of read. None of them, all of which is true, but this is kind of showing that there are studies kind of pushing the other way, showing that long-term use of medications seems to really do a number on the brain and make symptoms worse. Conversely, studies of mental health programs in Europe that do not use medications, and there are programs we'll talk about that do not use medications or very limited medications to treat schizophrenia, they appear to demonstrate reduced hospitalizations, increased return to community and work. This fits the pattern of the third world. This fits the pattern of these studies before this country really got into the meds for schizophrenia. Again, not saying this is the answer or this will even work in this culture of this country, but again, it's very significant. You can see how the United States, a whole approach to mental health, may be really having an influence on schizophrenics. We seem to be maybe making them worse or classifying them as worse or overly medicating them. It kind of begs those kinds of questions. Not that those questions have been definitively answered, but it's odd that in Europe, without these programs, without meds, schizophrenics seem to do better. This shows you this study. This is a dated study, but again, there's limited data on individuals who are on meds. These are ones that were on a placebo and then they didn't have any meds at all. Limited N here, limited number of people, but these are ones that were on antipsychotic medications and they came off the medications. They were on placebo, then they went on meds, and these were on the meds all the way. So the ones that had no medications at all, the severe difference analysis was profoundly less. The hospitalizations were profoundly less compared to the ones who were on medications. This, again, is contradictory to a lot of other studies, but it begs the questions, and it fits the pattern about Europe and other countries. Here's another one showing the long-term recovery. The individuals who did not take medications, they seem to get better and better, but those on medications just seem to kind of progressively get worse. So it seems like medication compliance, which we always put such a big emphasis on, and we should, that's what the doctor wants, but it appears to improve symptoms over the short term. We definitely know that. Over the short term, the meds are great. What do? They stop the voices. They stop this stop these psychotic episodes in their tracks. A patient is hearing voices. They become suicidal or violent or outbursts or whatever. The police or whoever take them to the emergency room, put them on meds, calms them down. In a lot of cases, it literally saves their lives. So the meds definitely have a role, but how are we measuring improvement over the long term? How are we measuring quality of life? It's kind of stopping the voices versus lost quality of life. Because life on the medications, the schizophrenic medications especially, is not pleasant. A lot of schizophrenics say it's kind of they lost their sense of who they are. A lot of cases, they just feel awful all the time on the medications. That's why they stop taking them. It's not because they're forgetful or whatever. It's because they hate feeling awful all the time. So it's feeling awful all the time, maybe staying out of the hospital, versus feeling better, at least for the short term until you have a break again. It's kind of back and forth. You can argue both ways. We do know this. Long-term use of schizophrenic medications, they are heavy duty. They really do a number on the brain. They cause Parkinson's-like symptoms, dyskinesia. Folks live shorter lifespans, affect the brain. They literally shrink the brain, muscle spasms, brain damage, possible sensitivity to more psychosis. Just very flat, indifferent. Life is not pleasant anymore. They talk about that. They feel very disempowering. Lost their voice, lost their meaning in life. So it's like, is this a good thing or a bad thing? It's very difficult kind of balancing thing. So let's kind of look towards Europe, look to these other programs. They're being tried a little bit in this country. What are they doing that's so different? And are they more successful than what we're doing in this country that has had limited success? I mean, if you look at it objectively over the last, 40 to 50 years. So in Finland, like in this country, there was just like a rapid rise, explosion in schizophrenia, explosion in the number of schizophrenics on disability. 25 new cases a year, it just kept going up. It's a small country of Finland, which is significant that it's small. 25 new cases a year. Nearly all of them became chronically ill on medications. So they were kind of desperate. Let's try something different. They kind of looked at it objectively and says, what we're doing is not working. These folks are just becoming more chronic, dependent on others. Their quality of life is just awful. Let's try something different. So they began something called an open dialogue program in the 1990s. We'll talk about what it consists of in a second, but the change was quite dramatic. Through this open dialogue program, which involved very little or no medications, the number of cases just kept dropping and dropping and dropping. It's now to just like 2 cases per 100,000 individuals. Schizophrenia has all but disappeared in Finland, and that's like a profound thing. They have the best outcomes in the Western world, it seems like, as we understand what they're doing more and more. So this is very profound. Would this work in our culture, in our society? I don't know. It's very much open for debate, but it's definitely working very, very well in Finland, this open dialogue. So what are they doing? They're kind of shifting the focus from meds and symptoms to relationships. And it's something that happens kind of between people. They're talking, dialoguing, working through the symptoms, that sort of thing, together, versus just giving a pill, tell me what your symptoms are. This is from a psychiatrist who's involved in this program. You can treat them without medication. They become more interactive. They become themselves. What are they doing? They're treated in the home for the most part. And what it consists of is the patient, their social network, their family or friends or spouse or significant others, and a healthcare team member. And they're just living together, and they start really quick once the symptoms start, and it's kind of a 24-hour thing. And they make treatment decisions around meds or whatever together. It's not this clinician making the treatment decision in isolation. It's the patient agreeing. It's the family agreeing. It's the clinician agreeing. And they're talking about the symptoms. They're trying to make a sense of the symptoms, words around the symptoms, understanding the symptoms, accepting the symptoms, accepting the voices. There's a big shift from what we do in this country. Principles, immediate help, family, social network perspective, flexibility and mobility, responsibility, psychological continuity, tolerance of uncertainty, and then dialogue, talking things out, reflecting on things is huge. Trained psychiatrists, clinicians, nurses, not focused on stopping the symptoms, focused on empathy, conversation, empowerment, understanding where they're coming from, understanding the severity of the symptoms, that sort of thing, helping them work through the symptoms. This kind of fits the theme of this class in terms of empathy, understanding somebody's story, understanding where they're coming from. Seems to be very, very effective with this program. We have to listen more to the patient's ideas about what is going on. Listen more to the family. Kind of summarizing the differences between the two countries, how we address schizophrenia. You can see the cultural kind of thing. In Finland, this open dialogue, it's community and family support. It's something that we're getting less and less of in this country. We're getting more and more isolated, less and less community and social support. People are on their own. They're stuck in institutions or assisted living facilities, boarding homes, that sort of thing. In Finland, it's more acceptance of the voices, acceptance of the bizarre behaviors. That kind of gets into that juncture thing. We're all different. It's just the way we are. It's atypical. It's typical. So the more acceptance of that, different definition of what's juncture. It's not normal. It's abnormal is okay. Whereas in this country, there's a lot of non-acceptance of voices and bizarre behaviors. We see those voices, we see those bizarre behaviors. There's something wrong with that person. We need to stop it. We need to fix it any way we can. Let's give them some meds. Non to limited meds in Finland, and that medication is a huge part of what we do in our health system. Not necessarily a bad thing, but it's a big part of who we are as a health system, who we are as a country. Our economy really is focused a lot on medications. Just stick on the evening news and watch the commercials. It's a big part of us. Finland, they think more of the long term. They were trying to get this person back into the community. They know the medications are not going to get them there. They're going to make them chronic and dependent. So we want to get them accepting, working through these symptoms so they can function again. Whereas in this country, it's very short term. Everything is short term. The medication, insurance reimbursement is very short term. The research studies are very short term. These meds are great. They stop the symptoms. They keep taking the meds. They're going to, stay out of the hospital. Not looking at what's going on 5, 10 years down the line on the medications. Not looking at what the person's quality of life is, how integrated they are into the community 5 and 10 years down the line on medications. So it's very much a short-term focus over the long-term focus. And the bottom line is less schizophrenia in Finland, more with us, more chronic. Would this work in our country? It's up for debate. They are trying it in a hospital, McLean Hospital in Boston. They're trying to open dialogue with schizophrenia and bipolar disorder. And they're kind of shifting things away, like with the open dialogue. They haven't embraced it fully, but they are embracing components of it, trying to move from isolating the patients and controlling the key holders, the clinician that holds the key, locks them in kind of thing. Moving away from that paradigm of control versus more patient input and control. Again, more social, relational, egalitarian. We're all the same on the same footing here. It's not me dictating to you. Again, reducing the isolation. And they're integrating initial family meetings. This is in an institution. It's not in the home. Initial family meetings, they just do that in discharge, but they want the family involved right off the bat. And when they have team meetings, this is a big shift. The team meetings in the past, I know when I was at Acadia, the team meetings they did there, the patient was not involved at all. It was a psychologist and clinicians making these decisions for the patient. We knew what was best. And not that we didn't do what is best, or we don't do what is best in this country. But this is the paradigm shift. The patient's there. You're talking to the patient. Direct dialogue. You're listening, making eye contact with the patient. You're listening to them about these decisions around medications and whatever. You all have to agree. The clinicians, when they're communicating with the patients, again, a shift from medical terminology. You have schizophrenia. Your symptoms are voices, suicidal ideation, to the imagery you described in that hallucination was stunning about, whatever it was. So using the patient's words, using how the patient describes things, using stories for communication versus listening to symptoms. And again, that gets into the theme in this class of seeing the power of understanding the patient fully, understanding the patient's story. Just examples, we were seeing that last week, even with the pediatrics, with the telehealth. The more you understood where the kiddo was coming from, what was meaningful to them, what was meaningful to their family, the more meaningful you could make your telehealth interaction or intervention, music or drums that Eric like that kind of thing. So they stay attending and they're not, running off and not watching the screen for the telehealth. Same thing we're seeing in the home health practicums. It seems like students that really engage the patient on her level, especially recently, she's a challenging patient, talking about what's meaningful to her. Bingo, in this case, seems to work. Again, getting at the patient's level. The more you get at their level, the more effective you're going to be. And it seems to be the case what they're trying in Boston. What's happening, we don't really know. They clearly know there's been no clear quantitative studies, more qualitative. But the staff and the patients seem to love it as a positive reaction. And they think anecdotally the psychotic episodes are going down. So it may be the future in mental health that's going on in Boston. Okay, so let's shift now to ADHD. Another example of contextual mental health kind of influences. ADHD, attention deficit hyperactive disorder, it's just exploding in this country. Started in 1980. We first started diagnosing it. This is kind of dated data, but it's gone from 4.3% in 2003 to 7.3% in 2011, 43% increase. I'm guessing it's even higher now. As of 2011, 1 in every 10 children and 1 in every 5 boys, this is like a big boy thing, not only boys, but a lot of boys, are diagnosed with ADHD. Is that a good thing, a bad thing? Not sure. The jury probably is still out. Definitely it's a good thing for a lot of children, that it seems to help in terms of keeping up academically, keeping up behaviorally. Others, we're not so sure. Again, it's unique to this country. Like the explosion of schizophrenia is unique to this country. The explosion of ADHD is unique to the United States. Mostly U.S. phenomenon. You go to Canada, there's not so much ADHD. What is it? Is there something in the water in this country? You look at ADHD prevalence throughout the United States, there's some parts of the United States where there's very little of it, whereas other parts there's more of it. Again, why is that? Is there something in the water or something? What they do know, this myth that it's a neurochemistry imbalance, not really the case with ADHD. Not really sure the long-term impact of medications on children. Like Ritalin is pretty safe. It kind of washes through the body pretty quickly. So that doesn't seem to be that big a deal, but it can lead to other more serious medications or drug use. A lot of people will start out at an early age on Ritalin. They're more likely to get into other kind of substance abuse kind of issues. Again, let's look at the bigger picture, the rest of the Western world compared to the United States. You look at the school systems themselves. I think this is interesting and kind of significant. In other countries, there's more movement in early childhood education. In this country, we expect the children to sit and attend to what the teacher is saying, all that sort of stuff, at a very early age. And it's earlier and earlier that they're sitting and attending. More sitting, less movement, less testing, or emphasis on testing in early childhood education in other schools in the Western world. Whereas more and more so with our school systems, we're testing children at a very early age. And the consequences of these test results can be very, very significant in terms of funding, in terms of assessment of teacher effectiveness, efficacy, that sort of thing. So the teachers themselves are under a lot of stress for their children to do well, grade-wise, testing-wise. And the children that do well are the ones that are able to sit. Obviously sit and focus. So there's a big difference in terms of that. And again, the medication, less medication focus in other countries, it's a huge focus in our country. Again, thinking long-term over the short-term, and then the difference in the number of cases. Okay, then lastly, getting into some apps and technology. I think I'll stop this one and just do